Thank you. Yeah, so the next topic is a follow-up. We had a very long discussion about Ehlers-Danlos Syndrome at several recent meetings.
That's page 122. Thank you.
And at our last meeting, it was pointed out that there's another diagnosis code that's used for hypermobility spectrum disorder. And that was proposed for possibly being treated like Ehlers-Danlos, and staff were directed to look at that. So
I think most of this discussion happened at HERC last time.
it may have happened at HERC last time.
Oh,
There's discussion of both.
Yeah. So Ehlers-Danlos syndrome, we added coverage for. This is a condition that is highly related but different. The ICD-10 code, the wording is hypermobility syndrome. However, we had 17 public comments, and many people noted that the term used by patients and providers is hypermobility spectrum disorder. So when I talk about hypermobility syndrome, I mean the same thing. It's hypermobility syndrome or hypermobility spectrum disorder. One is the sort of code description, the other would be the sort of description in use. Hypermobility syndrome is when you have certain joints or other areas that have more movement than you would expect, but you don't meet criteria for Ehlers-Danlos syndrome specifically. When we talked about this for Ehlers-Danlos, there were criteria for diagnosing Ehlers-Danlos, but you wouldn't meet those criteria for hypermobility syndrome. There are some criteria for diagnosis of hypermobility syndrome. It's essentially you need 5 or more points on a scale called the Baton score, or 6 if you're a child. And then the treatments that are recommended for hypermobility syndrome disorder are similar to those for VbBS. So the paper that lays out sort of the criteria for diagnosis was published by Atwell et al. In 2021. So they use the Baton score, again, affirmative answer of 2 or more out of 5 questions, being very sensitive. And they talk about the different types of joints and different degrees of laxity. Again, we had quite a bit of public comment on this topic.
And those can be found on page 126.
And in general, the public comment was all in support of adding coverage for Ehlers-Danlos, which is one of the options that staff will talk about in just a second, as well as that concern about the terminology used. There were papers submitted they were mostly general reviews. And then one was a early laboratory study about a biomarker as a possible test for Ehlers-Danlos and Hypermobility Spectrum Disorder. So in summary, this code M35.7, which is Hypermobility Syndrome, specifically in coding manuals, it's not to be used for EDS. It's used in practice to code for Hypermobility Spectrum Disorder. The proposed diagnostic criteria are in Atwell 2021. And the treatments that are proposed for this condition are similar to EDS. So there are two options proposed by staff. The first is to make no change, somewhat because this is a much less defined condition. The second option, which was overwhelmingly preferred by our commenters, was to add the hypermobility syndrome diagnosis to the same diffuse disease of the connective tissue line that we had moved Ehlers-Danlos to, and then modify our new guideline for Ehlers-Danlos to include hypermobility syndrome or hypermobility spectrum disorder. And it would include a clause that hypermobility syndrome, also known as hypermobility spectrum disorder, is included on that line when you meet all of the following criteria: a Baton hypermobility score greater than or equal to 5 out of 9 points in adults, 6 out of 9 points in children, and 4 out of 9 points in adults over age 50, and one or more secondary musculoskeletal manifestation, including post-traumatic symptoms, pain, altered proprioception, kyphosis, scoliosis, and joint misalignment, and do not meet the 2017 International Classification for Diagnosis of Ehlers-Danlos Syndrome. And then adding references to hypermobility syndrome where it refers to EDS in the treatment section. Discussion.
Hi, this is Mary. I think it's a good discussion, and I know it's becoming a very politicized area. I have ongoing concern based on consistent patterns of chart reviews. We see that the diagnosis is not substantiated, and that it's kind of become a niche diagnosis and concern of over-medicalization. And I'm really concerned that there's literature that supports this. So those are my thoughts.
Mary, can I just ask, clarifying, do you mean that it's there's not a clear definition for the diagnosis? There's not a clear set of, is it a definition issue for diagnosis?
Or a documentation issue?
Or is it, is there documentation?
I would say all of the above. People are getting the diagnosis, patients are getting the diagnosis, and you read the chart notes, and there'll be requests for various services, wheelchairs, what we would consider very high-risk medications for these conditions that could potentially lead to weakness and falls. You read the notes, like my cousin always said, I have hypermobile joints, therefore. And the patients receive, and this is a consistent pattern, and it's nationwide and it's worldwide. There was an article this week, interesting, it's a light article, but it's interesting, about over-medicalization in the Wall Street Journal. But I'm not aware of any medical literature that supports this, unless there's something I'm completely missing, and we're just seeing really concerning chart notes.
I'd say I have similar experiences with, there doesn't seem to be consistent criteria, nor is it consistently applied. But I think I had similar concerns with Ehlers-Danlos, and that one does have consistent criteria, but rarely do I see it consistently applied. So this seems even more amorphous.
So even when there is consistent criteria, it's not consistently applied to get to a diagnosis.
I can think of one chart maybe I've ever seen that actually applied the Ehlers-Danlos on hypermobile, because that one has specific, relatively well-known criteria. I think I can think of a chart for hypermobile version where they actually charted, these are the criteria, this person meets these. Rather, I have more amorphous kind of subjective reporting where I see it diagnosed, or it's just the person says they have it, so it gets added to a chart. That happens frequently, and then they kind of put a note that says, well, they told me this, and I'm not sure there's all these questions, but that diagnosis is still put in the chart. So for these, which is even more less defined, I have even more concern.
I agree with Max, and I think there's risk of harm. And the risk of harm that we're consistently seeing is patients receiving treatments that don't appear appropriate, high risk. 21-year-olds ending up in wheelchairs, group 3 wheelchair requests, which is horrible, right? Falls. And then also, I don't know if every CCO is having this, but I suspect they are, that we're having neurologists, rheumatologists decline to accept referrals because there's the diagnosis don't appear substantiated and overdiagnosis, and it's just it's so I that confers to me a risk of not receiving appropriate diagnosis. So I think this is not an issue that's without potential for harm.
Yeah, I've seen it.
saw-
Oh,
Oh, sorry, Sarah, I saw you nodding your head. Did you have something to add?
No, nothing to add. Just a lot of people do self-report.
Yeah, and just remind everybody, we did receive a number of written comments on this, and those are in the issue set. But there are patients who are very concerned about this and having a lot of trouble accessing the care they feel they need. Just want to make sure that's a part of the discussion.
Yeah, there's lots and lots of things to read there.
This is
Anybody
Chris.
else? Yes, Chris, please.
What I was seeing is that there is an attempt here to actually lay down some criteria and putting as a guide. Perhaps there is, I think the risk for harm is real, and I'm just wondering, I was seeing that adding the criteria might inform the providers and the patients to know what to look for and what to advocate for in their charts to receive that treatment, because it looked like there was some clear guidelines that they could use and some measurements that are added here to improve the reporting and the guideline that may not. So I guess what I'm looking at is there's usually self-report, but then it's usually part of the role of providers to substantiate, right? So if we're putting it out there as code guidelines for the coverage, do you think there'd be an uptake in utilization of these tools to improve the substantiation for and differentiate those that meet the criteria and don't? I guess it's kind of a general question, but Mary, I'm wondering if you think that might help.
I don't know if that would help. I'm worried about I'm trying to think of how to really carefully phrase this. I'm worried about giving substantiation to I don't know. I don't know if I can answer that question. Right now what we're seeing is apparently everything meets the criteria, and it is definitely a practice among specific providers where this is, and they're giving scores, right? So what we're seeing now when I think about this, they're giving scores that do not appear substantiated based on the exam notes or the history and physical that we're seeing. So I don't know if this would make a difference or give more credence to misdiagnosing. Like, I said they have this, therefore they have. So I don't know. We'd probably have to get a neurologist or rheumatologist to speak to this. And when we've tried that before at meetings, they didn't want to participate. I think because this becomes such a politicized issue that no one wants to discuss it publicly. So I don't know if others have different thoughts about that.
I'd be cautious because there are other things like MCAS, which has actually a laboratory diagnosis. I often see that diagnosis on a chart, even with notes that says we did the test at the appropriate time and it's still negative, yet the diagnosis persists. So I would be cautious even if adding that would add to it. And I'm sort of thinking of it as for the evidence-based committee, right? And there's not a ton of evidence both supporting this diagnosis and treatment, how it aligns. And it sounds like even that, if I understood right, the suggested criteria doesn't seem to represent the experience of the patient population based on what was reported in the public comments. That was kind of what I gleaned from that. They said it didn't kind of encapsulate their full experience.
Well, they were saying it is a highly variable and every person has a different set of symptoms. There's some patterns. it's distinct from hypermobile EBS, but it's not less severe. Those are some of the themes I saw. And so it just seemed very difficult to know what specifically you would do differently for this.
And the diagnostic criteria is just flexibility through the joints, right? That's what Brighton scores, which doesn't seem to encapsulate the experience that they're describing.
There was chronic pain, there was, a lot of different symptoms discussed.
So I'm not sure how helpful and representative that is of the issue and what we're hearing you need to help with. So I'm not sure that that criteria would be incredibly effective. And I think we have to, and it's not a fun acceptance, but science progresses at a different pace than guidelines do, right? So we're always going to lag a little bit with our understanding and based on, we get new diagnoses, there's early information or new treatments, and those develop, then they show that they're reliable or repeatable or effective in terms of treatment. And I'm hoping we're at the early stage in this develops and get a better idea and narrow it down now, but it doesn't seem like we're at our standard level of evidence to substantiate a diagnosis.
So just to play devil's that, or not devil's
Where
advocate
is that
really,
line?
but so in 2027, we will have to have this diagnosis be covered, or at least office visits and evaluation. Would it be helpful to have the guideline change then to include these criteria at that point? Or would you like to just kind of keep it as a diagnosis that's just in the evaluation and management grouping?
I think it's closer to 2027. Frankly, because I think these things change a lot in 2 years. We could have a very different either understanding or public sentiment about it or approach to it. As of now, actually, I probably said no as of now because I don't think that criteria seems to cover what they're discussing. To me, that's more a problem of we're not capturing the things they actually need help with, which we can get through comorbidities, and that's a systemic communication issue, not we need to add a diagnosis issue. So there's clearly an unmet need. I don't think we answer it with this. And I'm not sure we can answer it with that diagnostic criteria either.
Anybody else online? Lucy? David? Thoughts?
This is Chris. I'm sensitive to the risk of harm that I'm hearing Mary say, and I'm just wondering, we often will put kind of guide rails or like a follow-up or some review to kind of check for that harm. If it's pain management, is there any way to link it to some of those guidelines or set like a frequency for review?
So let me
From the provider to look at that part, to look at that care plan or those aspects of their
so just
plans.
to
It
understand,
is so variable.
when folks like this have certain things like back pain or neck pain, that would then fall onto a covered line and allow them to then have access to the services under guideline note 56, which includes chiropractic and massage and PT and acupuncture. And so, these things are already being done currently for funded comorbid conditions associated with this condition. So those things are already being done and I think widely taken advantage of and used and utilized and helping people.
That's the barrier that I heard at the first public comment, was that they were just not even indoor.
Yeah, the thing that I've heard asked for that would not be covered would be like physical therapy to strengthen muscles to prevent injury. Because someone has this condition which puts them at risk, and that's something we reviewed for hypermobile EBS and did not find evidence that it prevented anything. There wasn't a lot of evidence, but that's.
And as a general principle, the Oregon Health Plan doesn't do things to prevent a possible thing like a skin ulcer or it's written in OAR. There's lots of things that we don't do as preventing a not exactly inevitable outcome.
So the proposal, I'm just make sure I understand. So we're talking about making the criteria more restrictive so that we're no longer overdiagnosing people with a questionable condition, this hypermobility syndrome, which might or might not, but it's just very loosely defined. And we're going to restrict to some extent the coverage for that condition because we're saying it's not the same as Ehlers-Danlos syndrome. Am I understanding that?
Is that what option 2 gives us?
Option 2 gives the current standard guideline criteria, which I was hearing from Max may or may not actually be something that is useful.
And
But
option
it-
one is
so I
to
think-
change, right?
I think there's
Option 1 would not change.
There's two
Not
options,
for-
David, right now that we need to look at, and option 1 is to leave it like it is, which is non-funded, which does come with, like we talked about, when those other funded comorbid conditions exist, they get treated. Or moving to option 2. So I think if we want to take a look at page 124.
So if we do move it from the line where it's no minimally effective treatments to something where it would be a covered condition, what are the treatments? Because when I'm treating and looking at this, I go from more of a preventative standpoint and look at physical therapy, but given our OARs, we can't do that. So we would be treating with what?
So currently, the line that's being proposed does not have physical therapy because we didn't find any evidence of effectiveness for Ehlers-Danlos. And since this is an even less defined disease, I don't think you're gonna find anything. They would have access to medication subject to PA, although they do now, as long as they're not PA, like ibuprofen or an antidepressant or something that we don't PA. Office visits, education, DME, but that would require them to qualify for the DME through the rules. So like a wheelchair, you need to qualify for.
And there'd probably be other comorbid diagnoses that would be necessary as well, right? I don't know.
I mean, that should be documented, if a patient has multiple conditions, yeah, that should be taken into account. Yeah, so on that line would just be, I guess medications that do have PA would have to have, they couldn't have a not funded condition just stop. They would have to go down to some type of way to get coverage. Would be the one major change.
It's still have to meet that PA criteria,
Yeah.
nothing's FDA approved. Each individual CCO can do what they want, but it makes it unlikely that if you're PAing something, if you're not PAing it, then it's the same as now. So probably a small percentage that would go through that, require PA, and then get approved by the PA for a non-FDA approved condition.
Yeah, specialty visits, but they should at least have an evaluation visit covered at this point. Yeah, it essentially the coverage is very similar to what it is now in uncovered line, except for possibly the PA medications and maybe a little bit easier access to some DME. If it's, kind of a DME that's not really, doesn't really have requirements like split maybe.
We don't even PA things below.
Right, yeah, I think they should have that
So
now.
Technically, DME still requires some level 1 diagnosis.
Yeah, I'm just thinking if you don't PA like
Okay.
a cock-up wrist splint or something, because it's not expensive, they're probably already being able to access that.
Our website.
Yeah,
Other
so
thoughts, discussion, suggestions?
Can you summarize again, just to make sure I'm really clear, the difference between option 1 and option 2 in terms of like which is more liberal and which is more restrictive? Because it's confusing with this.
Well, I think it's confusing because it is confusing, David,
Yeah.
because I think there is some risk in operationalizing option 2 in actually
Yeah.
limiting things. And whereas right now with option 1, folks may be getting again through the other conditions and symptoms that come with these conditions, they are getting treatment and care. Whereas if we really try to pin down this diagnosis, many fewer people may actually have the diagnosis and then fall elsewhere.
And I guess you could have a third option where you move the diagnosis to a covered line, which wouldn't really effectively change in reality things without changing the guideline. That you could, we could modify and do that as a third choice.
Well, if you did that, though, medication and medical equipment covered for that diagnosis, there'd be no guideline to.
Yeah, be much bigger.
Yeah, so in 2027, no matter what we do now, this diagnosis will be covered. We have to cover all diagnoses. And it would be,
But for primary care office visits.
primary care office visits, medications, diagnostic testing, and DME that they qualify under DME rules. And
Which in all honesty, most folks are getting now.
yes.
We don't deny conditions in a PCP office, especially when often this is not gonna be the only thing they're being seen for.
Right, essentially, we think that the 2027 change for a lot of these diagnoses is really no change. It's just acknowledging that we do actually provide some care. So option 1 would be kind of delaying official coverage until 2027. Option 2 would be adding official quote unquote coverage in October with the guideline. And this option 3 that we could think about would just be adding coverage in October without a guideline.
I think, and the guideline, function of the guideline would be to limit it, or require those charts to support the diagnosis.
Which again goes back to what we talked about earlier, that without clear diagnostic criteria, there's a lot of folks with walking around with this diagnosis who may even be getting many things with lots of side effects that they didn't need. Did that help, David?
Yeah, thank you.
Good.
I'm sorry that I'm just, it's.
Oh, no, we're all in the same boat. Or the more we talk about this, I sometimes think the more confusing it gets.
It's confusing.
Brian? Yeah, Brian? Just acknowledging that it's.
Yeah, I'm just acknowledging. Yeah, I mean, I don't know that I have any great insight into it because, yeah, it's hard to kind of wrap my mind around a little bit. So.